Welcome to Facing the Future, brought to you by the Concord Coalition on WKXL, New Hampshire's talk radio station. I'm your host, Bob Bixby. Each week, we take a nonpartisan dive into topics related to the federal budget, the economy, and how it all affects our nation's future. This week, we'll explore healthcare and the federal budget with our guest, Anna Bonelli, Director of Health Policy for the Committee for a Responsible Federal Budget. Anna held multiple roles in the federal government before joining the committee. She worked at the Centers for Medicare and Medicaid Services and also led projects at the Government Accountability Office, analyzing programs across the federal budget. Anna, welcome to Facing the Future.
Thank you so much, Bob.
Well, as we're recording this, the government remains shut down. Don't know how long that's going to last, but and the reason is no appropriation bills have been passed for the fiscal year that began on October 1st. And one reason is a dispute between Democrats and Republicans about how and when to address expiring enhanced subsidies for people who get their health insurance through marketplaces established by the Affordable Care Act. Those enhanced subsidies expire at the end of the year. So I want to talk about that. Generally speaking, the Democrats are saying we want to negotiate that as part of the budget deal, and the Republicans are saying, well, let's get the government back open and then we'll talk about it. So I'm not going to ask you to unravel all the politics of that, but I thought it would be a good idea if we went over kind of the basic factual background here with these expiring subsidies, because they are very, very important to people. So basically, what are we talking about here? I keep emphasizing they are enhanced subsidies that are expiring, not all of the ACA subsidies. So what are the enhanced subsidies?
Yeah, it's a great question. It's so confusing. I definitely understand why people in the public are not following this blow by blow game that we're playing here. But essentially, so the ACA was passed, right, in like 2010, and initially it provided subsidies to everyone who enrolled whose income was below 400% of the federal poverty level. So for a family of four, I think it's, around $70,000, $80,000, something like that. And so, so people who had incomes below 400% of the federal poverty level, FPL, were entitled to some subsidies, right? So then, that was working between 2014 and 2020. Along comes the pandemic, and Congress saw fit to pass additional subsidies, these enhanced subsidies. So the enhanced subsidies lay on top of the original subsidies. So it makes it extra confusing because even some people who were entitled to the original subsidies got even higher subsidies under these enhanced subsidies that were passed in 2021 and then later extended. So the enhanced subsidies basically just discount these the premiums for ACA plans for people based on their income. So people at very low incomes pay almost nothing or nothing for just the premiums for their ACA plans. And then as you go up the income scale, people receive an additional subsidy. And then once you get to 400% of the federal poverty level, some people still qualify for these enhanced subsidies. So the enhanced subsidies go on top of the regular subsidies. These expire at the end of December, and like you said, it's causing quite a bit of concern in Congress.
I think that one of the things about as you described it, that people are concerned about is that income, that level where you don't get any subsidies. They changed that in the enhancement, and it used to be at 400% of poverty you were cut off, and that it developed a sort of cliff effect. So I understand it. When these expire, the cliff effect comes back into effect. So
Exactly.
it would be people at 400% would, if you earn $1 more, you don't get any subsidy, something like
Yep,
that.
that's exactly right. And that's a big part of the discussion because, like you said, under the original subsidies, you earned 401% of the poverty level, and now you're not entitled to any subsidy. Under the enhanced subsidies, there's no income limit. You can earn quite a bit. However, the way that the enhanced subsidies work and the way that the original subsidies work is as a percentage of people's household income. So it people, super wealthy people are not really entitled to these subsidies, right? Because the cap on the amount that they have to pay is limited to 8.5% of their income. So if you're a millionaire, 8.5% of your income is way more than any of these ACA plans. So those people are not going to be getting subsidies. But the enhanced subsidies did away with that cap, and if they go away at the end of the year, people who make 401% of the federal poverty level will no longer be entitled.
So it's going to be sticker shock. It probably already is for people, because the plans, the insurance companies that have to offer these plans are making their, putting out their bids, putting out their plans for now. And they're assuming that a lot of people are going to drop off because they won't be able to afford the new prices. And that sort of has a vicious cycle of increasing costs for everybody, because you get the healthier people are going to say, well, maybe I can go without health insurance. And it's going to be a quote unquote sicker risk pool, more at risk pool. And that makes the insurance companies raise their premiums. So it's kind of a cascading effect that will have an impact on everybody, not just people that lose their subsidies.
Yeah, that's exactly right. People are starting to, go online. It's open enrollment time right now. It started November 1st in most places. Everybody's going online. They're pulling up their state's website to see what the premiums will be this year. And because federal law at this time dictates that the enhanced subsidies expire at the end of the year, they have to show the premiums and the subsidies for what they are, which is, again, back to that like lower original ACA rate. And so, yeah, people are really stunned. Premiums are rising in general. They're rising, in part because healthcare costs rise, from year to year. Healthcare costs have been increasing, and that's not terribly surprising, but, they typically healthcare costs have often risen beyond the rate of consumer inflation. And so, here we are again, costs rise. But as you said, costs for these plans are also rising, and not just because things get more expensive from year to year, but also because insurance companies looked at the situation and they said, okay, like if we need to cover the cost of all these people in our plans, we're anticipating a less well population, less sicker population, because when these enhanced subsidies expire, people who tend to be healthier, tend to be higher income, tend to have other options perhaps for health insurance, like their employer-sponsored insurance might look more attractive. Those are the folks that are going to opt out of the marketplace, leaving a sicker population, meaning the health insurance companies need to raise premiums in order to cover all their costs.
All right, so I want to get look at something that's near and dear to the Concord Coalition and to the Committee for a Responsible Federal Budget, which is the budgetary impact of all of this, and kind of budget process stuff. I mean, let me ask you this first: why are they expiring? I mean, I think people get really uh, frustrated because we just went through this with tax cuts that were expiring and had to be extended. So you have this thing that people have become dependent on, and it's automatically expiring. So let's go through that. I mean, why do we have expiring subsidies?
Oh, well, lots of reasons. One is, that's the process, like an appropriations process, right? These are not necessarily mandatory benefits. Um, remember when this was passed during the pandemic, it was passed in large part because we had this kind of crisis situation on our hands. And so it was in many ways meant to be a temporary enhancement to a benefit. And so, there is some logic to having these temporary benefits, that when we're in a state of difficulty nationwide, that we do emergency things, and there's some logic to that.
Yeah,
Um,
no, I mean, I can see that. The tax cuts were kind of normal policy that were meant to enhance growth, if you believe it or whatever. But I mean, it's kind of the logic was permanent there, but but in this case, there is a temporary nature to them. And so, the fact that they're expiring shouldn't be, but then you get back to the, okay, well, people have gotten used to it. So
Right, right. Well, the other reason you make things temporary is because they're so costly. It's really hard to, in Congress, it's hard to look at the score of a bill over 10 years and vote for that. If you break it into chunks and you make it expire, it makes it maybe a little more palatable for Congress to pass. So in this case,
Well,
I
before
don't.
you get into that, because this is a good subject for the break. When after we come back after the break, we'll talk about that cost. And you're listening to Facing the Future. I'm your host, Bob Bixby, and I'm talking with Anna Bonelli, Director of Health Policy at the Committee for a Responsible Federal Budget. We'll be right back after these short messages. Welcome back to Facing the Future. I'm your host, Bob Bixby, and I'm talking about healthcare and the federal budget. My guest is Anna Bonelli. She is Director of Healthcare Policy at the Committee for a Responsible Federal Budget. She's worked in the federal government at CMS, Centers for Medicare and Medicaid Studies, and at the Government Accountability Office. It's a good thing you're not there now because they're shut down. So
Yep. So GAO is shut down. CMS has been recalled, actually. I think most of my colleagues from CMS are working to issue
they have
some
to
direct.
work.
Yeah.
Well, we're talking about the shutdown, and one of the reasons for the shutdown is a disagreement between Democrats and Republicans about what to do with the expiring ACA enhanced premium subsidies that go away at the end of the year. And both sides seem to want to do something about the increases in premiums that would happen, but there's a disagreement about whether to do that before they settle the budgetary issues or after they settle the budgetary issues. So let's get back to the expiration of these subsidies. There's a cost involved to the federal government if these subsidies are going to be extended, because they do expire at the end of this year. And if they do expire, people would not get as much of a subsidy, or maybe lose any subsidy that they're getting at all. So, Anna, if Congress just decides to extend the subsidies that are in place now, what is the cost impact to the federal budget?
Mhm. Well, the Congressional Budget Office has estimated that the cost would be about $30 billion a year and about $350 billion over 10 years. So the enhanced subsidies are quite a costly program.
And if the Committee for a Responsible Federal Budget has put out some statements on this, and one of them is, if you're going to do it, pay for it. Can we take that as a given that that's
Oh,
your
yeah.
position?
Yeah, absolutely. It's right there in the name. It's we would advocate that Congress be responsible. Like you said, this isn't a program that is very important to a lot of Americans. And some have, as you said, have found it worth shutting down the government over. And so if it is a priority of Congress, then Congress should make sure that it doesn't increase our federal deficit even further. So we've got a lot of ideas about how to do this. I think, one thing that I've been really intrigued by is the lack of discussion on how to moderate the size of the subsidies. There's just a real dearth of discussion. It feels very black and white. It's like we extend these enhanced subsidies or we don't extend them. And there's a lot of gray area in between. You could shrink the size of the subsidies in order to moderate the cost. So for example, we've looked at some proposals that would sort of move that line back where it's really hard to explain, but if you imagine that the line of the amount of income that people, the percentage of their income that people have to pay as their income rises, goes up and up and up. You can move that line so that it's between the line for the enhanced subsidies and the original subsidies. And that would mean that people at more moderate to higher incomes would pay more than they're paying under the enhanced subsidies, but would pay less than they would pay, under the original subsidies. There's a middle ground there. And so we would encourage Congress first to look for ways to shrink the size of the subsidies to something that is tenable but can be paid for.
And I guess you could do something with the, who gets the full subsidy, and that cliff that we were talking about at 400% of federal poverty level. You could lower that and save some
Mhm.
money.
Exactly.
Uh,
Yeah,
and
I would say, oh, sorry. I was just gonna say, uh, most people who receive these subsidies and the biggest dollar amount is really not at that upper end of income. There's just not that many people at higher incomes that qualify for the subsidies. So, I think the go-to idea, is always like, well, we'll just like, cut it off at 700, 600% of poverty level. Well, you could do something like that, but it really only saves, a few $billion a year.
and I think you said, I mean, that CRFB said that calculated at about $50 billion currently goes to households with more than 5% of poverty. I think that's true. You can confirm that. If you, uh, but so I mean, there is some room. Like you said, it doesn't have to be an all or nothing
Mhm.
thing. There are uh, ways in between where you could keep some of the reform, but not everything that went into the enhanced subsidy that was enacted during the pandemic and intended to be a temporary boost. Um,
Mhm.
there are some now, if they're going to be, even if it costs less, if you find some way to extend some of the subsidies but not all of the subsidies, there'd still be some cost to the federal government. So are there ideas that you have for offsetting that cost?
Yeah, absolutely. I mean, we've got a whole bank of offsets on our website for healthcare and all kinds of other things. And we hope that everybody would take a look, and especially, policymakers. We've got millions of ideas. There's different ways to look at it, right? So when you're offsetting in a policy area, maybe you look to just that policy area, right? And so within the sort of ACA marketplace policy area, one really obvious offset would be to fund cost sharing reductions. So these are, super wonky, but some people call them CSRs, cost sharing reductions. So as part of these ACA plans, originally when they were funded in 2010, people with very low incomes were entitled to reductions in the amount of out-of-pocket costs that they pay. So there were some technical issues on the Hill where these cost sharing reductions were never quite funded properly. And the plans in the ACA marketplace responded by increasing plans premiums at the silver level, because that's how you calculate these plan subsidies. And sorry for everyone who's just listening, because I use my hands a lot, and it seems to make more sense if you can, see somebody sort of acting it out. But it's very complicated, but the upshot is cost sharing reductions were never actually funded by the federal government. And as a result, plans increase their silver tiered plans, and that increased subsidies across the board. So as a result of all of this, because these CSRs were never fully funded, the federal government is actually paying more total for all of our ACA plan subsidies. So we calculate that, or sorry, CBO calculates that if Congress just simply appropriated the money for CSRs, that we could reduce spending by about $50 billion over 10 years.
Well, and
So
that
that's
would, yeah,
one.
that would uh, certainly make some headway in paying for things that if you're going to extend these subsidies. Um, I want to talk about I want to transition into Medicaid and Medicare. But you know, we talked about there's a standoff here between Democrats and Republicans over this. CRFB put out something noting that the Democrats' proposal to reopen the government would be the costliest ever in history because it's not only extending the subsidies, but rolling back some of the Medicaid cuts that were included in the Republicans' tax bill. So I'm assuming that that is the overall proposal here is a concern budgetarily.
Yeah, of course. Yeah, the proposal to roll back all of the reductions from the OB3, the reconciliation bill that was passed into law this summer, without offsetting those reductions is a real concern. Obviously, different sides have different policy priorities, but to just simply roll those back without offsetting them would be a major concern when we have a federal deficit at $38 trillion.
Yeah, and certainly there are opportunities to pay for some of those things as well. Okay, we're going to take our second break. You're listening to Facing the Future. I'm your host, Bob Bixby, and I'm talking with Anna Bonelli. She is the Director of Health Policy at the Committee for a Responsible Federal Budget. We'll be right back after these short messages. Welcome back to Facing the Future. I'm your host, Bob Bixby, and I'm talking about healthcare policy and the federal budget with Anna Bonelli. She is a former federal employee of the Centers for Medicare and Medicaid Studies and the Government Accountability Office, and now she is Director of Healthcare Policy at the Committee for a Responsible Federal Budget. And healthcare policy has a lot to do with the federal budget. Anna, we talk about the major healthcare CBO often just refers to a category as major health. When they talk about that, what are they talking about?
Oh man. Okay. Well, they're talking about primarily three major programs. I like to toss in a fourth, but I mean, the major federal programs are Medicare, Medicaid, and the ACA exchanges, which we've been talking about. But don't forget about CHIP. That's a little guy, but sort of goes along with Medicaid. So Medicare annually is approaching $1 trillion in federal spending. Medicaid is a bit less, although it has more enrollees, believe it or not. And the ACA exchanges, I think, let's see, we're up to $122 billion a year in federal spending. So these are a significant portion of our federal budget. And they're also really helping to drive some of our deficits annually. And that's why we spend a lot of time thinking about ways to address costs.
I think it's somewhere around 28% of the budget. That was based on the Treasury's report for the end of 2025. What do the projections look like?
Over 10 years for Medicare, we're looking at $13 trillion in spending over 10 years for the federal budget. So that's just a tremendous amount of federal spending that's going to just one program that primarily benefits one segment of the population. When it comes to Medicaid, we're looking at over 8 trillion over 10 years, and for ACA over 1 trillion. So these are just incredibly expensive programs, and as time goes on, they're eating away more and more of our federal budget.
And when we think of Medicare, also somewhat Medicaid, but more Medicare, we think of the aging population, the baby boomers. But it's more than that. It's not just aging baby boomers.
Yep.
We're responsible for a lot, but we're not responsible for everything.
No. Certainly not. No, people with serious disabilities and people with kidney disease are all eligible for Medicare. And so that can cover a lot of different ages. People who enroll on those bases often incur a lot of costs for their healthcare. So it's an important driver of spending in the
I
Medicare
think one
program.
of the things too that is, I mean, I guess this is the great conundrum that people have to figure, policy analysts have to figure out, and lawmakers is we tend to have healthcare costs in this country tend to rise faster than the economy is growing, and so even if we didn't have aging baby boomers, we'd still have growing healthcare costs because it tends to outpace the economy. Is there now this is a kind of an unfair question because it's a huge question, but why is that? I mean, why does
Oh my
healthcare
gosh.
rise so fast?
Yeah. I mean, this is the question that has launched 1,000 studies, right? There are many different drivers. A lot of people would say that it's prices, that Americans pay more for each service than they do in other places. Now, why that is another part of the conversation. Definitely, demographics make a big difference here. You're right that baby boomers aren't causing all the world's problems. That's certainly true, but certainly demographics are a big driver. A lot of people point to the cost of drugs as a big driver as well. More recently with GLP-1s, these are incredibly important, in some cases life-saving medications, but they can be very costly. And the same thing goes with technology. We have technological improvements from year to year, and that's very exciting. And that's typically very effective for, say, acute care and so on, but they cost a lot of money, to implement these things and bring them online. So lots of drivers.
And when we think about the federal budget and Medicare, that brings to mind the Medicare Hospital Insurance Trust Fund, HI, Medicare Part A. Uh, it's verging on insolvency, I guess. When is the projection for the HI Trust Fund to become insolvent?
2032. Yeah. So the trustees put out a report every year, the Medicare trustees, they actually projected that the hospital insurance trust fund would run out of its reserves in 2033. However, because of the bill that was passed this summer, OB3 or HR1, that bill will decrease the revenue that's going to our hospital insurance trust fund. And so we project that that will move up the date of insolvency to 2032. So that's only 7 years away. It is a real concern. Once the hospital insurance trust fund runs out of its reserves, then it's only going to be funded by the amount that's coming in year to year by tax revenue, and it's not going to be able to keep up. And we project a 12% cut at that point in the amount that CMS can pay providers. So these are, hospitals, some post-acute care. If you just imagine what it looks like when a hospital faces a 12% cut, that is a really dire situation. So we're really encouraging Congress and everyone to look for ways to shore up the funding of the trust fund.
Yeah, I guess you could find more providers not accepting Medicare. I mean, it could have some impact on accessibility, I would
Yep,
think.
that's exactly right. If you had a 12% cut among hospitals and some nursing facilities and so on, for one, you would see a lot of closures. You would see a lot of hospitals shutting down entirely. And then you might see some hospitals just withdrawing from the program and saying, we're not going to participate in Medicare at these levels. And then that would make things really difficult for a lot of beneficiaries.
Um, Now, there's also the Part B and Part D, the SMI, Supplemental Medical Insurance Trust Fund for Medicare. We don't hear about that becoming insolvent. Why is that?
Yeah, so the SMI trust fund, it's sort of a trust fund in name, but it's not really a trust fund in the way that the HI hospital insurance trust fund is. It's not money that is dedicated and sits in a bank like just for this purpose. The SMI trust fund is funded through general revenues, and so it's not in danger of running out. However, interestingly, the SMI trust fund, like the services that it funds. So as you said, Part B and Part D, these are like, doctor offices and drugs primarily. These services are actually, the cost of those services is actually increasing faster than hospital costs. So we project, or the trustees project, that over time, the amount of Medicare spending to doctors and to drugs will actually grow at a much faster rate than for hospitals. But nevertheless, we don't worry about insolvency because there's not like this, pot of money or this bank of money that is being depleted in the same way.
Well, that makes it a budgetary problem, I guess, because it's got this open pipeline to the Treasury. So if costs are expanding faster, it just comes out of general revenues, and
Exactly.
maybe that's why costs are expanding faster. I don't know. I mean, I think a lot of seniors say, well, I pay premiums for Part B and Part D, and isn't that covering the cost? Why should that be part of the discussion on budgetary matters? But as you were saying, it's how much of the premium, how much cost do the premiums cover?
It's a premiums. So the federal government pays about 75% of premiums and beneficiaries pay about 25%. And so, yeah, as these costs continue to rise, beneficiaries are just going to be paying more and more out of their pockets every month. So it's a real concern. And this is one of the main reasons that that we are looking for all kinds of ways to reduce the costs of federal healthcare spending, not just not just like, reduce benefits here and there.
Yeah, because generally, I mean, it's the cost of providing the healthcare that is, globally, that's a problem. It's not just the aging, and everybody, that rises cost for everybody, for states, for families, for insurers, and anyway, so we have to do a better job of, I guess, providing healthcare more efficiently. Um, and we can talk about some of that and some opportunities to do that. On the other side of the break, you're listening to Facing the Future. I'm your host, Bob Bixby, and I'm talking about federal budget and healthcare and the federal budget. My guest is Anna Bonelli. She is Director of Healthcare Policy at the Committee for a Responsible Federal Budget. We'll be right back after these short messages. Welcome back to Facing the Future. I'm your host, Bob Bixby, and I'm talking with Anna Bonelli. She is Director of Healthcare Policy at the Committee for a Responsible Federal Budget. And we're talking about healthcare and the federal budget. It's a big part of the federal budget, about 28%. So, uh, and rising. So, Anna, I wanted to first, we were talking a little bit before the break about Medicare Part A and its pending insolvency. I just want to mention that you folks at the Committee for a Responsible Federal Budget have launched a trust funds solutions project, which includes not only Medicare Part A, but Social Security and the Highway Trust Fund as well. Do you want to just get in a quick plug for that?
Sure. Thank you so much, Bob. I really appreciate it. Yeah, we've launched a trust fund solution initiative project. We had a launch event last week with Dr. Oz presenting on the hospital insurance trust fund, and we'll continue to have papers and events that really take a big picture view of, what can lawmakers do to reform compensation taxes and healthcare costs as time goes on in order to avert some of these, really consequential insolvencies that could occur over the next 10 years.
And they can see that at crfb.org, I
You
guess.
got it. Thank you.
Okay. And all right. So let's, I want to talk about some problems with Medicare Advantage. Before I do that, I want to bring up briefly Medicaid, which was part of the One Big Beautiful Bill Act from last summer. And it got a lot of attention because there were cuts of about $1 trillion from the baseline to Medicaid. So obviously that part of it got a lot of attention. Democrats objected to it. Um, so let's, and as part of their proposal to reopen the government, they're still saying that we should reverse those cuts. We talked about that a little bit in the last segment, but what about one of the things that was included is something called a Medicaid provider tax gimmick. Um, and they cut back on that in the bill. Could you briefly describe what that is?
Yeah, great question. Again, healthcare, super complicated, but essentially, you have to remember that in Medicaid, states reimburse providers, say hospitals, for their services, and then the states go back to the federal government and say, okay, we paid these hospitals, now reimburse us, the state, for that payment at a certain rate, right? So it's a program that is jointly financed by both the state and the federal government. So that's sort of the dynamic that leads to some kind of funny business when it comes to financing. So what happened is many decades ago, states started to tax some of these providers. So they'll put a tax on hospitals or nursing facilities or whatever. Then they will take the funds and in many cases just return those tax funds to the same providers in the form of a supplemental payment. So not necessarily a payment based on, one service, but a lump sum payment several times a year. And so after they pay this lump sum payment, then the state goes to the federal government and says, well, we just made this lump sum payment. Please reimburse us at the percentage that we're due. So it's, 50, 60 cents on the dollar. So through this mechanism, states are able to generate all this extra money because if the state is obtaining revenue and then paying it back to hospitals and then getting reimbursed, the state is able to retain a lot of extract and then retain extra federal dollars. So this is a scheme that's been going on for many, many years and really started to become exacerbated in the last 5 to 7, 10 years as some of these supplemental payments were really growing and growing to the point where a lot of providers, such as hospitals, were receiving payments that were more like commercial insurance rates, well above the cost of providing the services. So due to, this long ongoing practice that states and providers were doing together, Congress decided to restrict this practice, and they are freezing provider taxes in many states and sort of ratcheting them down over the course of a couple years. So what you'll see is that states are losing a funding stream that they had in the past, but it's going to save the federal budget. I think it's around $130 billion over time.
And let's talk now about Medicare Advantage. Making a hard pivot here. But we're talking about overpayments in a sense. So it's the same type of thing of getting at overpayments. At the Committee for Responsible Federal Budget, you've put out a lot of papers about Medicare Advantage and how it is overpaid. Briefly, well, doesn't have to be too brief, but could you sort of explain what Medicare Advantage is and why many people say it is overpaid? It's very
Yeah.
popular.
Yeah, it really is. Medicare Advantage is actually more popular than traditional Medicare at this point. More than half of Medicare enrollees enroll in these private plans called Medicare Advantage that are sort of overlaid on top of just the regular traditional fee-for-service Medicare program. These plans are like, plans you've heard of, like United and Cigna, Aetna, et cetera. And they essentially administer the Medicare program for over half of beneficiaries at this point. They are large companies that work with plans and providers nationwide. So what happened was, when MA, the Medicare Advantage plan, was conceived, it was thought of as a cost saver, right? Because plans should have this incentive to reduce costs, because if they reduce costs, then they actually get to pocket the amount that they're saving the federal government. So there's a strong incentive for them to save money. But unfortunately, that has not happened over time. In part, that is due to the fact that the way that MA plans are paid is that they get additional funds for each beneficiary who joins their plan based on how sick they are, right? So, which makes perfect sense. You would definitely you want to make sure that these plans are not looking for only healthy people. We want them to serve everyone. So, the federal government pays plans a little bit extra if somebody enters the program who is more ill than your sort of average traditional Medicare beneficiary. And as people join the plans that are sicker and sicker, the plan gets more and more money. And that makes sense so that they can cover the cost of this person who is sicker and sicker. The problem is that over time, plans have gotten really good at making the people that enroll in their plans look as sick as possible. And in some cases, some of these diagnoses are questionable. And the way that they do this is through all kinds of different means, but it has really exacerbated the difference between people who are in the traditional Medicare program and people who enroll in Medicare Advantage. So now everyone who enters, for every enrollee who enters Medicare Advantage plans, those plans are paid way more to care for this person than they would have than the traditional Medicare program would expend if that person had stayed in the traditional Medicare program. So it is driving costs like crazy. It's kind of shocking. Our Committee for a Responsible Federal Budget, my organization, projects that the costs over 10 years of Medicare Advantage plans, upcoding, like overbilling the Medicare program, will cost the federal government over $1 trillion over 10 years.
That's certainly significant savings if you could get into that.
Yeah.
There are other, I think the CRFB noted something besides the upcoding, other problems with Medicare Advantage as well.
Yeah, there are a number of different problems with Medicare Advantage. For example, there are incentives for employers to enroll some of their retirees into Medicare Advantage plans. And it gets a little bit complicated, but it essentially sort of cherry picks some healthy individuals into MA plans who are then, the plans are eligible for these quality reward programs. And so plans who enroll lots of these retirees are eligible for all these extra quality bonus payments that they really don't deserve. The quality bonus payment is another place where we think there could be a lot of reform and $100 billion or more in savings.
Are there any effort, by the way, at this time of year, we're all seeing flooded with TV commercials of Medicare plans, and it's all benefits for nothing. You get no copay, and you're going to get dental and vision and hearing and a gym membership and everything. And if you wonder that it's perhaps because you're getting some extra money from, so anyway, great if you can get it.
Yeah, that's such a good point, and people often don't like connect those two things. People in MA plans, in some cases, really do receive these enhanced benefits, like hearing and vision care, our gym membership, these are some really desirable benefits in some cases, and they do have some value in many cases. But taxpayers are paying for those benefits, and it raises questions. Why are some plans able to fund these sort of extra benefits when, people in traditional Medicare, et cetera, are not getting those benefits? The dollars to fund those services come out of taxpayers' pockets.
Yeah, and it's not a surprise that Medicare Advantage has gone, it's just ballooned in the last 10, 15 years to, as you said, I think it's over 50% now of people on Medicare are signed up for a Medicare Advantage plan. And you'd almost, I don't want to say you'd be a fool not to, because there are a lot of people that don't for various reasons. But if you can get extra benefits and not pay more, why not do it? So anyway,
Exactly. Right. There's a real logic there. Unfortunately, sometimes you can't get the services that you need, not for everyone, but some people really cannot take advantage of MA plans and those extra benefits. And so they really need the traditional Medicare program, and that's great.
and they
But
might not be available everywhere. I mean, the plans might not be as generous or as available to everybody. So there are reasons, but it's certainly an opportunity for savings. We're going to have to leave it there. I'm your host, Bob Bixby. You've been listening to Facing the Future, and I've been talking with Anna Bonelli. She is the Director of Health Policy at the Committee for a Responsible Federal Budget. Uh, Tune in again next week. I'll be back with another edition of Facing the Future.